Well, hi everybody. Thank you, and it's great to be able to do this. I got to say, for me, this is strange because I'm talking into the phone and can't see all of you. But I do want to talk about Massachusetts, what's happening in healthcare, both what's happening at the state level and at the federal level, and how it affects Massachusetts. So I want to talk just a second about healthcare for all. Because you can't see me, that's me in the top picture speaking at a rally we had over the summer in front of the federal office building as the Obamacare bill was going to be voted on for a repeal part in Washington. Healthcare for All is a consumer health activist organization. We see ourselves as the voice of patients and consumers in Massachusetts healthcare. And it's important that I say in advance that we definitely have a point of view. I'm going to try to be objective and present information without too much bias, but you should know in advance that we certainly are here in favor of the ACA, in favor of Massachusetts health reform, in favor of issues that affect consumers, so you know where I'm coming from. We also, you should know, have two partner organizations that we work with that you may want to consult with. One is Community Catalyst. They are a national consumer health advocacy organization. They grew out of Healthcare for All. Their lead sort of core senior staff is the former core senior staff of Healthcare for All, and they work on national issues. They work with about 40 states. The other organization that we work with closely and is our partner is Health Law Advocates, and they are a legal organization. They work with lawyers, and they represent consumers, patients who need legal representation on healthcare issues. And together we share the same office. We work together real closely. The other thing I want to say about Healthcare for All is we operate ourselves a helpline. It's an 800 number. They answer about 20,000 calls a year from people who need help signing up for health insurance or wanting to understand what is covered by their coverage. And this might be a good resource for you in your day-to-day work, or just people you know, relatives, whatever, who have problems with their health insurance, want to know where to turn for help. It's interesting, if you call the Medicaid, the Mass Health, they know a lot about Mass Health, but they don't know about the connector or exchange. If you call the connector, they know a lot about the connector, but they don't know how Mass Health works. Our counselors know about all the programs and is a really terrific resource. The other thing you should know is more than half of our calls are answered in Spanish or Portuguese, and we really have the language capability, and that might be useful for people you know who need help in their language. Our website is on the screen, hcfama.org. There's also our blog on the website, which is a good way of keeping up with state health policy. So let me get going. When we talk about health policy, there's two big concerns in addition to quality, which we'll talk about at the end, and that is coverage and cost. So here's the umbrella representing coverage, the dollars, the money representing costs. And in addition to coverage and cost, there's two other overlays that I want to talk about, and that's both state government issues and federal issues. So we have sort of four cross-cutting issues: coverage and cost, state and federal. I'm going to try to bring you up to date on all of those, but there's obviously a lot going on, and so I can only hit some highlights. So first off, on the coverage issues, Massachusetts is the best coverage rate in the country. We're number one. The latest report shows that we have 97.5% of all state residents have health insurance. For kids, it's even better. It's 99%. And we should be proud as a state that we have the highest coverage rate. We're considerably higher than the number two, which is, I think, 95-point-something%, and they go down from there. We've been improving on our health insurance rate for years. Each report that seems to come out since the mid-2000s is better than the one before. And people ask, so why are we so good? Why are we the best state? And people talk about our tradition of coverage, that our economy supports employer coverage because of the kind of companies that we have here. And our Medicaid program, which is called Mass Health, has been around for a long time and is pretty expansive and broad in its coverage. So all of those points are true, But I would point to one to two actually key reasons as to why our health insurance coverage is so strong compared to other states. And that's the combination of Romney Care plus Obamacare. And so the Romney Care bill passed in 2006, and that's Mitt Romney in the back signing the bill. Behind him are state officials. If you went across from left to right, there's a Republican, a Democrat, a Democrat, a Democrat, a Republican, and then another Democrat. The Romney Care bill had bipartisan support when it passed, and then our bill in Massachusetts became the template, of course, for Obamacare. Now, in the Obamacare picture, there's only Democrats. That was not a bipartisan achievement. It was very much a partisan effort. But, of course, it could have gone the other way. It didn't have to be partisan because certainly a lot of the ideas in the ACA, in Obamacare, was based on the bipartisan ideas from Massachusetts. And so I think when we look at Obamacare and think about the politics of Obamacare, it didn't have to be such a partisan issue that it is today. And the latest development of yesterday, actually, was this bipartisan agreement that was announced to make some repairs to Obamacare. It's something we'll talk about later, but it represents, I think, the core ideas of health reform that were very much consensus ideas on a bipartisan basis. So this idea that we relied on Romney Care and Obamacare to improve our coverage rate makes a lot of people ask, well, if the ACA was repealed, at least we'd be protected in Massachusetts. We could always go back to our Romney Care law. And that's not true, and I'll go into some more details in a minute. But I think in general it's important for everybody to understand that the Romney Care law depended on federal Medicaid funding. And so if the ACA was repealed and Medicaid was cut back substantially, that would also hurt us in Massachusetts. We couldn't just go back to Romney Care. What we did here in Massachusetts is when our law was passed in 2006, the state went to the Bush administration and said, can you provide funding for this under what's called the Medicaid Waiver Authority? So the federal law, the federal Medicaid law, allows states to propose innovative new ideas and get Medicaid funding for those ideas. And that's exactly what we did back then, is we said, let's consider the state funding, the sliding scale subsidies for coverage under our exchange as if it were Medicaid funding for purposes of federal funding. And so we got federal funding for our initial connector expansion subsidies, and that Medicaid funding was half of our cost. The way Medicaid works in Massachusetts is it's half federal, half state funding. And so if the ACA was repealed and we were to lose that Medicaid funding, we would lose coverage here in Massachusetts. So the question on everybody's mind is, will Obamacare be repealed going forward? And the answer is, I just don't know. I'd love to say there's a crystal ball, but we really don't know. So remember, back in May of this year, the House barely passed their version of the repeal bill. The vote was 217 to 213. It was brought up then in the Senate a bunch of times. None of the various options that were proposed was able to get the majority of votes needed to pass. The final vote barely got a majority, got 51 votes, but I got 49 votes rather, did not get the 50 votes. The opposition was 51 votes. And so that bill, which people called back then in July the kind of skinny repeal, and the one thing you should know about the skinny repeal bill is even the 49 senators who voted for it didn't actually want it to become law. And normally when you vote for a bill, it's because you want it to become law. But everybody, not everybody, but most of the members agreed that it was just a vehicle to get discussions going between the House version and the Senate leadership, but it wasn't actually something that they wanted. And then later in the fall, in September, there was yet another attempt to figure out a way to do something about the ACA. And this proposal was called the Graham-Cassidy bill. And what the Graham-Cassidy bill would have done is allow each state to make their own decisions on what they wanted to do. So the marketing was actually pretty attractive. The marketing was, if you like Obamacare, you can keep it, and if you don't like it, you could get rid of it, and each state was going to be allowed to make up their own decision. The problem was what the Graham-Cassidy bill did is take the money from the 31 states that have expanded Medicaid and spread that 31 state money over 50 states. And so for a lot of states, it would have meant a decrease in their funding. For a few other states, it would have been an increase in the funding. And because of that, they weren't able to get the support they needed. And so that bill wasn't even brought up for a vote. So here we are today with no legislation being able to pass in the U.S. Senate to repeal Obamacare. So the next step for President Trump is, can I somehow sabotage what is going on with two kind of contradictory goals. One goal is to do what he's wanted to do all along, which is repeal the ACA. The other goal, which is somewhat at odds with that, is can this bring Democrats to the table and we can cut some kind of deal that would make changes to the ACA that I support, that's both a Republican and a Democratic bill. So these are some of the things that have been pushed in the last 2 weeks or so. One is there were cuts to the outreach and enrollment assistance that states rely on to get people informed about how the ACA works and how people can sign up. Second was changing the contraception requirement. Under the ACA, certain preventive care treatments and diagnostic procedures have no copay and no deductible. And what President Trump and the Trump administration did on that was instead make it so that organizations that have moral objections to paying for contraception could get out of that requirement. Now, what had happened before on this is under the Obama administration, they had let church-related organizations get out of the contraception requirement, but they had figured out a way for insurers to offer it anyway, just not using funds from their employer. And what the Trump administration did last week was allow that to just not be provided at all. The third thing that's been in the news the most lately is something called CSR payments. So CSR stands for cost-sharing reductions, and under the ACA, people who get help through the exchange, in Massachusetts it's through our connector, have two kind of sources of reimbursements. One is discounts on the premiums, and the way that works is the individual gets federal tax credits to make up for for their lower premium costs. The other set of subsidies are these CSR payments. So the health plans are required for low-income people to give them discounts on their copays and deductibles. And then the health plans are reimbursed by the federal government through this CSR mechanism. And what the Trump administration agreed to do this week was not pay these CSR payments to the insurance plans. And then the fourth thing I could mention is the president signed an executive order last week. I think, was it last week? It was the end of last week. My timing, this is all moving so fast. Directing federal agencies to allow what are called association health plans. Association health plans is something that exists in current law, but currently they're allowed only for small periods of time and only for certain businesses. The proposal was to allow that to be expanded so that companies could band together, small businesses can band together, and this would allow them to bypass some of the ACA requirements, particularly the requirements about no pre-existing conditions discrimination, no gender discrimination, and allowing them to offer benefits that aren't required under the ACA. So the question is, how do all these kind of sabotage policies affect us here in Massachusetts? And it depends on the issue. So in Massachusetts, we don't rely on these outreach and enrollment funds. We use our own state money because we don't have the state national healthcare.gov exchange. We have our own connector. So these cuts don't affect us here in Massachusetts. On the contraception requirement, bill was negotiated between some women's health advocates including us here at Healthcare for All, and state-based insurers to basically substitute a state requirement for the federal requirement. So that bill has broad support among legislators, among insurers, and among health groups. And so that bill, it looks like it's going to pass before the end of the calendar year, that would substitute a state requirement for the federal requirement. On the CSR issue, and I just got to interrupt myself by saying all of this is really, really complicated, of course. This joke where Trump said, "Who knew healthcare was so complicated?" is so often repeated in my circles, it's not even funny anymore, but it's absolutely true. And so we'll do have time for questions towards the end. So anyway, on the CSR issue, that could certainly affect us in Massachusetts. People getting subsidies through the connector are protected. What happens is if the CSRs aren't paid, it just means the price of insurance goes up. And if the price of insurance goes up, then their tax credits go up. So the premiums go up, their tax credits go up, and people getting subsidies are protected. But in Massachusetts, there's about 80,000 people who buy their health insurance through the connector who don't get subsidies. And those people would certainly pay higher premiums, around 20% more, if the CSR payments are not made. And, of course, there was a deal made yesterday on the CSRs. I'll talk about that in a minute. But if that deal does not happen, is not passed into federal law, those people would pay more. So yesterday it was announced that Senator Alexander, the Republican chair of the HELP Committee, which has health jurisdiction in the Senate, and Senator Murray, who's the Senate Democratic leader on that committee, have reached an agreement to make those payments, reinstate those payments, through federal legislation. And President Trump had 3 positions during the course of the day yesterday. He said he was against it, and then he said he was for it, and then he said he was against it. So it's quite unclear if the Senate is going to be able to pass this bill with presidential opposition. And then if the Senate passes it, then it goes to the U.S. House, and the Speaker of the House, Paul Ryan, has also made kind of negative signals, but not truly said he's against it or for it. So what happens to this proposal tomorrow that was announced yesterday, how this moves in the next week or two is really quite up in the air, and nobody knows what's going to happen. But you should know that about 80,000 people in Massachusetts would get hurt. Then the last thing is this association health plan issue. So in Massachusetts, we have our own health requirements that date back to the Romney Care era that protect people on the benefits side. But if the association health plan was to happen, and by the way, for this to happen, it's not based on the executive order. What it would require is that federal agencies to make the actual regulatory changes. If that were to happen, then people could be capped on their benefits. It could allow discrimination based on pre-existing conditions in Massachusetts. It could allow gender discrimination where women pay higher than men. So all of that could happen in Massachusetts if these federal agencies were to make those changes in federal law. So that was a bunch of policy analysis, and I know there's a lot there, and we can certainly talk about it later when we get to the question period. One more thing in terms of politics that I want to mention that's really important. On the left there, that's a picture of our Governor Baker. On the right there, that's a picture of our Attorney General, Maura Healey. Both Governor Baker and Attorney General Healey have been very active, taking 2 different approaches to what's going on with the ACA. So Charlie Baker has been very active behind the scenes, working with other Republican governors to make statements and work with other Republican senators pretty much behind the scenes to try to moderate or oppose a lot of these changes. And for us here at Healthcare for All, we've been actually quite appreciative of Governor Baker's activism on these issues. Just yesterday, Governor Baker signed a letter by a number of Republican governors and a number of Democratic governors supporting the CSR proposal and opposing the Trump administration's cutting off the CSR payments. So that's been one approach that Charlie Baker's taken. Maura Healey, as Attorney General, has taken a quite different approach based on where she is. What she has done is filed a number of lawsuits, and she filed a lawsuit the day before yesterday challenging the ability of the federal government to withhold these CSR payments. She's filed a number of other lawsuits on this issue with other attorney generals from other states. All of them have been Democratic attorneys general. And I think it represents the kind of leadership role Massachusetts plays on these issues. Two state officials each taking separate roles on this issue. So let me catch my breath, take a sip of water, and then talk about what's happening at the state level. So at the state level, there's big news happening this week. The day before yesterday, the state Senate in Massachusetts proposed a major health policy bill. It's very comprehensive legislation, and I want to go through some of the key ideas in that. There's, in particular, a major proposal around health quality that I want to talk about. This is the report cover that the Senate used for their bill the day before yesterday. And the main reason I'm showing it to you is I kind of liked their map of Massachusetts, showing all the icons for different healthcare-related things. Their slogan was Healthy Living, Healthy Massachusetts. And at the end of this presentation, I'm going to show you the website where you can get to this report and the big Senate bill. So the Senate bill was released, as I said, on October 17th, the day before yesterday. The bill is a big piece of work. There's 159 sections of their bill. It adds up to 101 pages of pretty small print. It is not a reaction to the Trump administration's actions on health care. It's actually something they've been looking at for over a year. A number of senators were on a special committee to look at this. The Senate had a year-long process. They went to Minnesota. They went to Vermont. They talked with experts in a number of other states before they came out with their bill. The bill is going to have a hearing next Monday of next week. The hearing starts at 11:30 on Monday the 23rd. And then the Senate is expecting their floor debate to occur in early November. The Senate session for this year ends on November 15th, and what the Senate leaders have told us is they expect this bill to be finished by the mid-November deadline. And then if it were to pass the Senate, and I fully expect it to pass the Senate, then it would go to the House. House leaders have been very iffy about this. They've been making noises saying, well, I don't know, this is a Senate initiative, it's not our initiative. And that's typical Massachusetts politics. If the Senate wants something really bad, the House says, we don't know what we think about it. If the House wants something really bad, the Senate leadership says, well, we don't know about it. And what it leads up to is basically a trade where the House says this is what we want and we'll agree to the Senate provisions if we get what we want, and vice versa. So I expect this to be a major issue in the House later in the spring next year once it passes the Senate. And how the House treats these Senate initiatives, I think some will certainly be supportive, some they'll probably not include, and a lot of it will be for negotiation between the House and Senate. So these are the big topics in the Senate bill. It deals with hospital readmissions and ED use. It deals with institutional post-acute care, insurance costs. There's some Medicaid reforms, prescription drugs, and prevention. And then, of course, it deals with healthcare quality, and I'll get to that at the end. So on the issue of hospital readmissions, you should know that in Massachusetts, we are above average both on readmissions, where someone leaves the hospital and comes back within 7 days or within 30 days. We're also above average on ED use compared to other states. And so the Senate bill proposes to focus on hospitals with high readmission rates. It provides for a kind of benchmark that it expects all hospitals to meet. And if you're above that benchmark, you're going to get penalized. It also authorizes what's called telemedicine, which allows people to be treated outside the hospital remotely. And it allows most providers to use telemedicine procedures to consult with doctors and hospital people outside the hospital. It also authorizes something called mobile integrated health. And this connects to telemedicine. It allows ambulances and emergency health providers to consult with people back in the hospital remotely. And the goal is so people don't get referred to an emergency department, don't have to be brought to the emergency department, and instead can be treated in their home by people that are on the first responder on the ambulance. On the institutional post-acute care front, it sets up a counseling program where people leaving the hospital are not necessarily referred to institutional care and instead can be sent home with counseling, and lets people know about their options for lower cost care. On the issue of insurance costs, there's a whole bunch of provisions in this bill. One of them is trying to reduce surprise out-of-network bills. So often when a person is in a hospital, they could be treated by an out-of-network anesthesiologist or other out-of-network providers, and then they get high bills for out-of-network care when they might have higher copays, higher deductibles, and the insurance has higher bills. So what this sets is restrictions on out-of-network payments, requiring that out-of-network payments be at the standard commercial rate. And for the patient's point of view, the patient would not have out-of-network copays or deductibles when it's either a surprise or they would have no ability to see that. It also has some things on copays. So it encourages insurers to charge little or no copays for preventive care treatments. So when I talk to experts on this, the things that they recommend is insulin for diabetics, or asthma inhalers for people with asthma, or very low-cost preventive care for hypertension or for antidepressants. And the idea is that the insurers would not charge copays for these services because they're preventive care and because they lower overall costs. And the whole idea of a copay is to make the patient think twice before I use the service. And we don't want diabetic patients to think twice about their insulin. We don't want them to think twice about asthma inhalers if the patient has asthma. And so the idea is to eliminate copays for those services. It also sets up a new specialty area called for dental care and oral health called dental therapists. So dental therapists are mid-level providers similar to nurse practitioners in a medical office, and this bill would authorize dental therapists to provide dental care. There's also a number of issues in the bill about lowering drug costs. One is something called academic detailing. So detailers, I'll start with detailers. Detailers is the name they use for people sent out by drug companies who meet one-on-one with doctors in the doctor's offices and are advertising, are promoters for the drug company drugs. So the detailers say, oh, you should use this drug, it's very effective for this, and the detailers only go out on the high-cost drugs. So what academic detailing is sending out counter-marketing, I guess. Instead of marketing high-cost drugs, the academic detailers present the best evidence-based and the best academic information on when to use one drug, when to use another drug, when to use a third drug. And the academic detailers provide objective, unbiased information for the doctors. There's also provisions in the Senate bill about transparency for drug prices. It requires the drug companies to testify every year on their high-cost drugs, on drugs in the pipeline, drugs that are coming that are high-cost, and to explain in public why their prices are so high, and it allows state policymakers to focus on their high-priced drugs with this transparency. Of course, right now, drug prices are a total black box. Nobody knows why drug prices are so high, what are the basis of their high charges. So this would do that. And then, as I explained earlier, There's also this provision to not charge copays for some preventive care drugs. Another issue that's not dealt with in this bill that we at Healthcare for All have been working on is the kind of wining and dining of doctors by taking them out to fancy dinners, fancy meals, serving alcohol at these educational sessions. So in state law, we used to have a provision saying that there's no gifts, including meals, are allowed to be provided by drug companies to doctors. That was reversed in 2012 when the state law passed a provision allowing modest meals to be provided to doctors. And this was a big fight at the state level. The bill to allow the meals to be provided was called the Restaurant Rejuvenation Act, and that gives you a sense of who is behind this. And so we allowed modest meals, and it was up to the Department of Public Health to define what a modest meal is. And there was a big fight at the DPH over this at the time, and what they eventually came up with was allowing modest meals as long as, and the definition of a modest meal was what a doctor would pay for himself or herself if the doctor were paying for it out of the doctor's own pocket. And so we at Healthcare for All were very discouraged by this. We thought it did not clamp down on these wining and dining meals. And so the end of this was that this was just a temporary measure, and in 2019 this wining and dining provision will be looked at again. And then the last thing I want to talk about in terms of the Senate bill that was introduced the day before yesterday is to preventive care and keeping people healthy. And there's a number of provisions in this bill that would work on overall health and preventive care rather than paying for acute care that's when people are already sick. And one thing in the Senate bill is reinstating the Prevention and Wellness Trust Fund. So the Prevention and Wellness Trust Fund was authorized, again, in this 2012 law that I mentioned. It focused on 4 issues where the hope was that we could spend money on keeping people healthy rather than spending money on people once they're already sick. So the issues that were focused on was hypertension, asthma, tobacco use prevention, and elderly falls. And the trust fund funded 9 local partnerships around the state of Massachusetts that worked on these issues, and the partnerships included local health authorities, local health councils. It included local hospitals, included medical groups, it included community organizations, and the reviews were very positive that they were saving money, that it was cost effective, but the money ran out in July, and these local partnerships are just kind of spending out their leftover funds. The Senate bill that was passed, that was introduced this week, would reinstate the Prevention and Wellness Trust Fund and give it a permanent set of funding. The other thing that I should mention that's going on in the state in terms of keeping people healthy is the Mass Health ACO program. So ACO stands for Accountable Care Organization, and ACOs have existed in Medicare for a number of years, and Mass Health, our Medicaid program, is planning on bringing ACOs to Medicaid. The ACO program will start in March of next year, and there's 2 innovative parts of the ACO program that I'd want to mention. First off, the ACO program integrates long-term care and behavioral health care into the ACOs. Right now in Mass Health, long-term care is quite separate from medical care, and the behavioral health program is quite separate. What the ACO program does is integrate long-term care and behavioral health care into the one system rather than having them as separate systems. The other part of the ACOs that's really revolutionary and quite dramatic is it provides funds for non-medical care. So right now under federal Medicaid law, you can only spend Medicaid money, of course, on medical care. And often ways to keep patients healthy and to save money involves non-medical care. Like the example that they always give, but it's a good example, is if a patient has asthma, they're not allowed to provide air conditioner in their home with a high filter, but yet that's exactly what the child might need to stay healthy. And so what Mass Health ACOs are going to be able to do starting next year is spend their money on things like air conditioners. They're also able to spend money on things like housing needs, and often housing is the biggest need that a patient has, and if the ACOs can work on the patient's housing needs, it can keep them healthy. What I also want to raise for all of you who work on healthcare quality is a key part of the Senate bill that was introduced day before yesterday. It creates a task force, and you can read it here, to work on aligning standard quality measures. One of the issues that they found, the Senate working group, is that our quality measurements are all over the place. That one insurer has one set of measures, the Group Insurance Commission, which is the state healthcare for state workers, has another set of quality measures, and what they want to do is have a standard quality measures that are all aligned among all payers and among all evaluators. So the requirement would be to work on consistent quality measures in all contracts, in all tiered network systems. So tiered networks is when patients have lower copays or lower deductibles if they go to in-network providers, and they have higher copays and higher deductibles for out-of-network providers. That's called a tiered network. The goal is to reduce the administrative burden so that patients, consumers can have to know what the quality measures are going to be and improve oversight and quality of care. So the law sets up this task force made up as the groups you can see here, the Commissioner of Public Health and the Health Policy Commission. CHIA is the Center for Health Information and Analysis. That's the state's data organization on health care. The GIC is the Group Insurance Commission, the state employee health care. Mass Health, and the DOI is the Division of Insurance. Also on this task force is the MHA, the Mass Hospital Association. MMS is the state's Medical Society. Behavioral Health and Long-Term Services, LTSS. Blue Cross is our largest insurer. MAP represents all insurance companies that are not Blue Cross. And then there's some consumers, people with disabilities, consumers, and performance measures experts. So all these groups will be on a task force, and what the law would provide, what the proposal provides, is this task force look at both national measures and state ideas, and they look at measures applicable to primary care specialists, hospitals, providers, ACOs. So there's a huge mix of healthcare quality ideas, and in the end, what they're supposed to come up with is an aligned measure set based on these recommendations each year, and these aligned quality measures would be uniform across the state for all purposes. If you want to look at the bill, I give the how to look at the bill. It's malegislature.gov, then committees, then detail, S1 and documents, and that would lead to the website that has the bill. I also showed you how to get to it on the state website, how to click each category and subcategory. And you can read the whole bill, but in Section 2 of the bill, it says how we set up the quality measures. And it's a long, detailed bill, but I thought that would be interesting for all of you on the phone. The last thing I want to talk to is just to take a step back in how I got into this, and to thank all of you for working on healthcare quality as part of your job. And then we'll get to questions and answers. So I was a young lawyer interested in healthcare interested in policy, not particularly interested in healthcare or any other issue. And I got a job, as you heard in my bio, at the State Senate Ways and Means Committee, which is the key committee of the state legislature. And when I got called in for my first day on the job, they explained to me that we have lots of staffers who work on different issues. There's one person who works on transportation, one person who works on education, one person who works on housing issues. And what they said to me back then in the late 80s in 1989, is the hardest, worst job in the office is healthcare. And since you're the new staffer, sorry, Brian, we're going to make you work on healthcare. And it was kind of like the booby prize in the office. And I said, okay, I'm happy to work on it. It's as good as anything else for me. And 2 weeks later, the staff director said to me, and he said, don't worry about doing healthcare, Brian. It's a great opportunity. We're never, ever going to fix healthcare, and so you'll always have a job for life. And that's how I got into the healthcare business. And the reason I tell this is, in my experience, and I'm sure in your experience too, healthcare is such an important issue for everybody, and yet it takes so long for us to get to healthcare issues. And there's so much complications. I guess I'll end where I started about healthcare being complicated. So this is a long battle, and a new bill was introduced 2 days ago in the state Senate, and that's going to be voted on. And at the federal level, there's so much going on in healthcare. But you all know how important healthcare is. And the work we do is important work, key work. It matters a lot to people. So I'll end there, and we can go to questions and have a discussion.
The conference has been unmuted.
Thank you, Brian, for taking the time to share with all of us today your expertise in Massachusetts healthcare policy. We'll now open the lines for questions and answers. Just a reminder for participants to please stay connected to the web presentation in order to complete your evaluation. Do we have any questions for Brian?
I felt like I was just talking, and there's lots of complicated stuff.
The conference has been unmuted.
There was a lot of excellent information, Brian.
Thank you.
Does anybody have any questions for Brian?
I have one question, but it wasn't brought up. Thank you, Brian, for your presentation. Do you have anything can you enlighten us a little bit about the staffing laws that are currently in the docket? The new ones, not the ICU ones.
You know, that's not something that I'm familiar with, these staffing laws. What I will say is I mentioned earlier, that there's changes to allow dental therapists to work in Massachusetts. They also expand the scope of practice in the Senate proposal for a number of other professions like nurse anesthetists and others. And I don't have that list in front of me, but you should look at the report that accompanied the bill. So in the web link that I put on the last slide, you can look at this report, and maybe I can look at it real quick too while we're talking about all the changes made into kind of scope of practice. But I don't know specifically about staffing laws you asked about. It's a good question, just not something that we work on.
Anyone else have any questions for Brian?
I just want to say it was a very good presentation. You made it very simple.
Thank you.
To understand. You're welcome.
To say it's simple is, I appreciate that, but it doesn't feel simple.
I know.
And it's changing more from, somewhere where we would read some rules within the Federal Register once a year to it's something new almost every week between the federal and the state level. Yeah. So let me just go back. The legislation expands treatment authority for nurse practitioners, for certified registered nurse anesthetists, psychiatric clinical nurse specialists,
for optometrists and podiatrists. So all those professions would have expanded treatment authority under this bill. And I think the goal is to lower costs by allowing lower-level providers to do more for patients, I guess.
Brian, when are the Mass Health ACOs, again, when are those going to be rolled out?
So there's 17 organizations that were certified as ACOs. They postponed the starting date. It was going to be in January. Now it's going to be in March. Starting in mid-November, people that are eligible for ACOs, and that's about 800,000 people are eligible for ACOs, are going to get notices about the ACOs. People can opt out, but the ACOs are going to be connected to people's primary care physician. And if your primary care doctor is an ACO doctor, if you want to stay with that doctor, you're going to have to stay in an ACO, is my understanding. And so, but it will start in March. To answer your question.
And that will tie into the new quality measures that they're looking to, at the state level, to collect?
Right. So these quality measures will, one, the bill that I mentioned will try to standardize them. But in any case, the ACOs will be getting paid differently, right? So the ACOs will get paid a capitation amount based on the severity of illness of the patients, and then the adjustment will be based on the quality measures of the providers. So if they provide higher quality care, the ACOs will be getting more.
Oh, that's interesting.
And that those quality measures haven't yet been figured out, and this bill that was just introduced would, right now it's under Mass Health jurisdiction to figure out these quality measures, but the bill's goal is to have one statewide quality measures for everybody.
Would they be reflective of the current Medicare quality measures? And I only ask because of the macro legislation that, physicians are now tied to, and then Massachusetts physicians having to report. Would it try to align with that as well? I mean, because that seems like a lot more work.
It is a lot more work, and that's why the proposal is to take into account. Where was that slide? To take into account also Medicare measures, but I think the feeling is that because Medicare has a senior and disabled population, and Mass Health has a separate population, so for now I don't think there'll be overlap, but not identical.
Brian, are the measures focused on acute care?
Yes. Yeah,
So
I think they are.
There's no measures for post-acute care.
It is wicked. Well, it would be with the ACOs because you've got the long-term and behavioral health, right?
Right. So I think for you guys who work in quality, and this is part of your work, I think it's important that you raise your voice so that the quality measures make sense for both acute care and long-term care and behavioral health. The more we can make these measures rational and workable, I think it's to your advantage, and your expertise would be really important in this. Because I'm sure right now you guys face such confusion in this whole area, and I'd love to hear if somebody wants to talk about that, what it's like.
Well, I work in post-acute care, but I work at a licensed LTAC facility. So at this point, there's very little public reporting of any data on LTAC licensed facilities under LTAC Compare, and we still struggle with it. But if you were, the measures that are defined for acute care really aren't applicable to our patient population.
Right. And then the other question I'd love to hear someone talk about is sort of process versus outcome measures, and how much should we include patient experience in these measures. My organization has always sort of said that there ought to be some way to take patient experience into account, but I know that's complicated, and I know the validity of those measures is really not agreed to by everybody, right?
Patient satisfaction is a tough measure.
I think certainly everybody agrees it should be there, but making it sort of workable and reflect actual care
Right.
is got to be complicated from your point of view, right?
Yeah, I mean, you know, you've got a third-party vendor sending out satisfaction surveys to patients, and you know, sometimes it's not the patients themselves answering those. You could have a family member who may not have been happy with something. And then the idea, and this is at the federal level, the idea that the patient has to answer questions in order for an acute care to score well, as always. And, you know, human beings by nature don't tend to answer those types of questions as always. They'll go to the next one, which is most of the time. So it's frustrating. Yeah. I don't think it shows a true picture.
The kind of flip remark we've often heard is the patient satisfaction is based on the receptionist being friendly or not, more than the medical care.
Yeah, there's a lot to do with it. So were there any other questions or comments or discussion that folks would like to bring up with Brian? All right, well, Brian, not hearing any, I guess we can go ahead and close out our event, and I want to thank you again. That was very, very informative, wonderful presentation.
Well, thank you. You know, making health policy is a mix of politics and policy. And that's why I focus on some political stuff as well. And I would encourage everybody to stay involved in policy, certainly, but don't forget politics as well, because if you have whatever your point of view, it's important that elected officials and state officials know what you're thinking.
Absolutely. Well, thank you again, Brian. We appreciate your time today.
Sure. Thank you all.
Thank you.